Hi, it's John Snyder. Welcome again to another edition of Newton-Wellesley Medical Group Lunch and Learn. We are happy to have today Dr. James Bath, who will be talking to us about autism, patient care, and transition planning. James, go ahead and go to the next slide, please. Before we let him start talking about autism, we're going to just tease a few things, our upcoming Lunch and Learns. Next week, we have a great talk about atopic dermatitis and eczema by Dr. Michael Crathen. Following that, Taking Care of Yourself, a nice talk by Lois Levin and then Levine, and then on the 26th, Approach to Diarrhea by Dr. Homenko. Just a reminder that all these talks are archived up on YouTube under Newton-Wellesley Medical Group Lunch and Learn, as well as also on our intranet. Next slide, please, James. Oh yes, we want to make sure people know of two learning opportunities. One is our monthly APP Grand Rounds hosted by Amy Israelian. These actually happen live and virtually. So if you're on campus, please come by. Check us out on Bowles 4 or 5. It's the second Tuesday of each month. This month we will have Sean Lear. She'll be giving a great talk on lung cancer screening. Please check that out. And also don't forget about Wednesday, 8:30 a.m. Department of Medicine Grand Rounds. Those are always amazing talks. We will continue. That will continue throughout the year. That's hosted by Dr. Larry Friedman, Chair of Medicine. Next slide, James. And real quickly, we want to make people aware our last edition, session 4 of Taking Charge of Financial Wellness, will be occurring on Wednesday, May 18th. That's not next Wednesday, but the following. That's right, the following Wednesday. And it is on estate planning. And we are very happy to bring back the folks from New York Life again to talk to us about this. We will be hosting that at 6:30 to 7:30. We've made that time on purpose. We also are archiving those talks if that time doesn't work with you, but we'd like you to be able to kind of get home and be able to watch this from the comfort of your home. We have picked out these topics in the whole world of financial wellness, so I hope you enjoy them. Estate Planning 101 is the next one, session 4, and our final session of this 4-session talk series. Next slide. And then we want to remind everyone, of course, about our physician care concierge service. May and June are incredibly busy times around the house. Need someone to go ahead and mow the lawn or figure out what kind of perfect Mother's Day gift to get you, or graduation gift, or where to have the party or get the cake, anything like that. This is a valet service that is free to you. All you need to do is sign up for that, community.circles.com, register with the welcome code NWH. They have helped me personally in many different ways, and they are there to help you, very non-intrusive. They'll do reviews of whatever service or that you're looking for, and they will actually give you great choices and even sometimes set up appointments for you if you'd like. So please, we're paying for this and we want you to sign up for it and use it. Thanks. Next slide. And I will let James take over. James, thanks so much for being here, and I'm excited to hear this talk. If anyone has any questions or comments, you can throw them in the chat box or just put your name in the chat box. I'll call on you at the end. Either way, whatever works for you guys. Go ahead, James.
All right, thank you, John. Thanks everyone for having me. I really appreciate it. My name's James Bath. I'm a primary care doctor who works at the Mass General Hospital Laurie Autism Center up in Lexington. I don't know if any of you have ever heard, but it's a great multi-specialty group up in Lexington that really caters to all the needs of patients with autism and other developmental disorders. I've been practicing family medicine now for about 15 years, mostly in the Medford-Somerville area, and up until recently was just doing general family medicine, but then got very interested and passionate about autism care, and recently made the transition to full-time. So I'm doing primary care, just seeing patients in Lexington every day now. And I thought this was it's a cute sign that's on a center right down the street from my house that I always like when I pass by it. And so I'm not going to spend a lot of detail going into, all of the things that go into an autism diagnosis. I really want to try to focus on the very practical and real things that you guys see in clinic and may have questions about. As far as autism goes in general, it's a disorder that is really the hallmark are reciprocal conversation, that not picking up nonverbal cues, maintaining relationships. Those are sort of hallmarks for every ASD patient. And then, some kiddos have and adults have the repetitive motions, the stereotypies, restricted interests, sensory issues, and a whole host of other things, but those are a little bit more variable. This link at the bottom, this CDC link, is fantastic. If you ever have a question, and you have a patient in the office and you're not quite sure, what these other definitions actually mean, it's really great for description. With autism comes either nothing else or a host of other things. It really depends on where the patient is on the spectrum. So these are some things that you might see associated with your patients who are, have ASD, which can be anything from sleep disorders to epilepsy, constipation. Those are really common. Obesity, anxiety, depression, learning disabilities, and for folks a little further down on the spectrum, the agitation and aggression and self-injury can be prominent as well and challenging. But there's usually a host of other things that go along with ASD that you'll see with your patients. Just as far as the numbers go, to sort of let everyone know what to expect over the next coming years, it's now down to 1 in every 44 kids are diagnosed with autism, and God willing, we will figure out what is causing it sometime this decade. There's still a lot of research being done, and some days it doesn't feel like we're any further along. But there's almost over 5 million adults, and there's going to be about a million teenagers aging into the adult population and over this decade. So a lot of patients on the spectrum who are going to be in our practices. The challenges, as you guys probably already know very well if you have any patients in your practice, is there's a real shortage of developmental pediatricians and pediatric psychologists and other specialists. And on the adult side, it's not so much a shortage so much as has been a lack of training over the years, just to really understand, what ASD patients really need when they come into the office or in their life. And so not a lot of great training. And then one of the things that we use for diagnosis is in great demand and in short supply, which is the be able to get certain neuropsych testing. That can be very challenging. But so those are the challenges that we just have to work through and continue to deliver the great care that you guys give. So if it's okay, I want to do this in 2 case studies, one for a kiddo, one for an adult, in hopes that it might stimulate some questions or that you might have. But this one is probably something we've all seen. You have a well child check, and about a 2-year-old, 2.5-year-old comes in, first time, maybe it's the parent's first child, not a lot of words, a lot of pulling and using more grunting and, physical ways to show them what they want, tends to sit by himself and, do preferred things, watch preferred things, doesn't like the sensory input, can melt down very quickly. And when he does his MChat, which is really helpful, I know it's just one of a number of big long lists that we have to look at during our well child checks, but if you have a suspicion, it's a great tool. And online, you can look how to score it, and that can sort of immediately set you in one direction or another in terms of what to do with this kiddo. And he happened to fall into a pretty positive number on his MChat. And so the most feared question comes at us, which is, what do I do now? And so, because the parents are worried and they don't know what to do, and they know something's wrong with their kid, and you've got to be able to figure out how to help them. Okay. And the thing I want to really emphasize is that as primary care doctors, it's not really going to be our job to manage everything that comes up with regards to the language and the motor control and the fine motor skills and all of that. Our job is more of a coordinator. It's to help guide the parents, give support, and get them on the right road. That's the best thing you can do by far. And if you have a suspicion, refer to early intervention as soon as possible. Studies have shown that early intervention, as soon as you can do it, is incredibly worthwhile. And early intervention is able to put in place a lot of things that the parents have questions about, like, how do I help them with his fine motor skills or gross motor skills? What do we work on with language? And early intervention can really do a nice wraparound service for them if we can get them in early enough. But as you all know, they age out at 3, so it's a time consideration. And then if you can, if the initial assessment from early intervention is that the child is very likely on the spectrum, has deficits, get them to developmental pediatrics on a waiting list as soon as you can. And all of the main tertiary hospitals, at MGB, Tufts, Boston Medical Center, they all offer developmental pediatrics, but they have long waiting lists. So you want to get the kiddo on there as soon as you can, even if it's 9 to 12 months. This, I was considering having this be my only slide in this because I hope it's the most useful. But as patients go from the youngest to adulthood on with their diagnosis and what they're going to need, this is a bit how it plays out. Early intervention to start, then you have to try to get the neuropsychological testing on board so that they can really establish the diagnosis, because that's what opens the gate for insurance coverage for all the other services. So that's why it's important to do early. And then ABA, which I'm going to talk briefly about, can be another important part, especially for younger kids, well, and older kids too. And then the more severe these patients are on their symptoms will sort of dictate what else we have to coordinate, because that may include getting neurology involved if they have epilepsy, if they've had a seizure, and developmental peds if the behavioral issues are really severe. And then as they go along age-wise, they may show significant issues with constipation or feeding issues like ARFID, which is just a very restrictive feeding disorder. They may need more intensive outpatient PT and speech outside of school or outside of even early intervention when they're young. So this is just sort of a stratification of the tools that could really help the parents and the patient get the most out of their care. And like I said, as primary care doctors, we don't do very much of this ourselves because there's specialists that do it. We just have to coordinate. And then as they get much older, you start to look into things like residential placement for if they're not able to live at home. So anyway, I hope this slide is useful for you. John, I think these slides are saved, or you can look at it on the video afterwards. So hopefully it'll be helpful. Quickly on ABA, because it seems to be a huge question for everybody. It's basically a very specific way you go about behavioral modification. And it's called applied behavioral analysis. And basically what happens is a trained BCBA comes in, evaluates a child usually in the family, in the home, sometimes in school, and really figures out, okay, what's going on? What are the deficits? What are the areas we need to work on? And then set up a very analytic plan about how to make change. And so they have the starting point, the midpoint, and then what their proposed endpoint. And it's just a very analytical by collecting data and just going over and over and over again with the patient and the family, how to modify that undesired behavior or that self-injurious behavior to hopefully extinguish it over time. So that's all really ABA is. It's just a very sort of systematic approach to behavioral management. And patients will often come to you as their doctor and say, can you refer me to ABA? And the answer most often to that is, no, actually you can't. It's either offered through early intervention, it's on the IEP at school, which is a critical thing for all of these patients, or the parent has to source it privately outside. And thankfully, there's a lot more than there used to be even 5, 6, 7 years ago, where they can call around to different private groups that offer ABA and get that in-home service that they're looking for. And then they have to work with their insurance company to get it covered. But there's no specific thing that you really have to do as a primary care doctor. So that's ABA in a nutshell. As the child sort of moves into sort of adolescence and adulthood, you start to have to deal with some other issues. You have to make sure that the parents are staying on top of their IEPs and their neuropsych testing is updated. Those are done every 3 years. And usually once parents are in this process, they are very aware of this. You run into the oh so wonderful puberty and teen issues, which aren't good no matter how you slice it. But can be even more challenging with kids who have sort of social emotional issues. But there's good things out there. There's social groups, and I'm going to talk about one that the Laurie Center offers via Aspire, which is great. And then guiding the parents to doing all of the medical legal things they need to do as the child gets older. So the second case is about a patient you might see who's transitioning out of pediatrics and coming to you as an adult patient. And in this particular case, Ryan's 22 years old. He comes with his parents and his group home manager where he recently moved. Generally a pretty happy young man, but he's got a complex history: seizure disorder, ADHD, constipation, sleep disturbance, some other minor things. And lately, what they're worried about, he's really become emotionally dysregulated. He's doing a lot more stimming behavior. He's rocking, he's, just does not appear to be his baseline self, but since he's nonverbal, he can't tell you what's going on. And this is always where the challenge comes in. And on top of that, mom and dad have a whole bunch of issues they want to talk to you about his transition. And so this is usually what I feel like most of us feel like when we have that first patient like this. And so, but there is to reassure you that it can be managed, and you almost have to approach it like any other sort of medically complex patient who may come in with COPD and coronary artery disease and diabetes. You don't deal with everything at that one visit. You just prioritize. You make sure you listen to the parents, hear what their concerns are. That's the most important thing by far. Make sure that nothing's going on that's really serious or can really injure, your patient. That's the other most important thing. And then you are just going to need time, and it's probably going to take multiple visits, checking in with other teammates, team members, that type of thing. So don't get overwhelmed, just prioritize, try to pick out the most important things. And the parent, if you do that alone, the parents will be forever grateful that you just listen to them and they know you're going to help take care of their kid. That's really what they want. Use the team, which by this point, since they're adults, they will invariably have a whole team put together already, from psychology, psychiatry, neurology, gastroenterology. They'll have those things, so you can draw on that. You just have to coordinate. And then as the visits go on, just make sure that you're not letting the preventative care stuff go. And the reassurance, like I said, is by far the most important thing you can do. If you have done that, you've done 99% of your job. Because being a autism parent is kind of like this. Someone sent this to me once, and a parent, and I thought it was very funny and very true. Being the parent of an autistic child, I can tell you it's often like flying in the dark. And so as much as you can help them, they'll forever grateful. Some resources that we have at the Laurie Center, if you need us, I offer primary care there now. If you feel like that would be an appropriate place for your one of your patients to land, but we have great neurologists, psychologists, psychiatrists, gastroenterologists, social workers. We really have a great team up there, and this is all they do every day. We have behavioral and educational consultants, which can be invaluable, especially as they get to the school age years, or need to think about placement, like in a school during their adolescent and teen years. Those are typically pay for services, but they can be found on the Laurie Center website as well and can be really helpful. Great social groups for kids who generally function pretty well, but really struggle socially through Aspire. And when they get older and getting ready for maybe looking at working, the Aspire Works program, which can help with internships and resume preparation, it's really wonderful. And also on the website for parents, there's great webinars on everything from guardianship to advocacy to how you maintain your sanity. And then also some clinical studies too, if they're interested. So it's a wonderful place. And if we could ever be of any service, absolutely give us a shout. So that was it. So if there's any questions, more than happy to help out.
Thanks, James. That's a really great overview. I guess I'll start off with a question. If anyone wants to either chime in with a question, either put their name in the chat or just speak up. James, one of the things that I find challenging in the office is, I'll ask it in two different ways. One is the parent of a 6-month-old who's deathly afraid that their child is autistic or will become autistic, and also the parent of an autistic child or a child on the spectrum who is blaming an event, and I won't pick on immunizations because we all have been down that road, but an event that has caused this. How do you suggest we kind of manage those issues in the office, and how do you do it, really, given all your experience?
Yeah, great question. So at 6 months old, you can tell them definitively, really pretty definitively, that it's too early to tell. As we all know, milestones are very much in flux at 6 months old. There's really not a whole lot of things that we can even focus on with regards to milestones. It really starts to show itself at around between 15 and 18 months. And that's what you can reassure the parents, is that, there's really no way to know this early, and that, this is why we see kids so frequently for their well child checks at, 6, 9, 12, 15, 18, is that we're constantly going to be asking them about what they're doing and what their milestones are so that we can catch it in time. So I think that's the answer to the first question. The second question, is a little bit more challenging because oftentimes the parent will have be predisposed to what they think the answer is anyway, especially with regards to vaccines. So, all you can do is really just be, present the data, and the data is really clear that vaccines and febrile, there's a couple things, vaccines, febrile seizures, there's a couple others. I can email them to you. I can't remember them off the top of my head. Given multiple vaccines at once, there's zero evidence that there's any link to autism. And I often then sort of convert the conversation to, we just simply don't know what causes it yet. We know there's multiple things that go into it. Some of it's genetic, but not all of it. And there are thousands of researchers, spending every single day trying to figure this out, and it will be figured out at some point, but we just don't know yet. And that vaccines are incredibly safe and incredibly protective, for awful diseases like meningitis and, pneumonia and these things that kids can still get, especially in a much smaller world that we now live in, where we're all in contact with people from around the world.
The question in the chat from Jen, who she wants to know, are there other groups as amazing as you guys are at the Lurie Center that are maybe in different areas like west of 495 and or national groups that offer virtual visits, or has that something that maybe is not as effective with this group, or maybe more effective?
Virtual visits definitely have a role. They can be great because these parents and these kids are busy. They usually have a lot of appointments and school schedules, therapy schedules. So virtual visits are invaluable, and I use them in my practice. We're one of the few dedicated centers in the area. And so I do have patients who come and see me from Western Mass, North Shore, New Hampshire, so I wish I could say there was more of us. There isn't. There's some awesome practitioners, but doing it a little bit more in a solo gig. All of the tertiary care medical centers, including UMass, do have sort of these concentrations, though, where they deal with primary care and kiddos on the spectrum and other developmental disorders. As far as nationally, Autism Speaks is by far, the biggest national group, but not from a therapeutic standpoint that I can think of. But they do have amazing tools for primary care docs and parents on their website.
And then Wendy Gaines has a question about what age would you suggest we screen with MChat? And I'll add on to that. And do you screen frequently or after that, or is it a one-time deal?
No, it's 18 months, and it's one of those things where if it's a questionable diagnosis, it's really borderline, and you're really just not sure, are the parents sort of being overly concerned, or is there something real there? I'll often pull a kiddo back in within 6 to 8 weeks. I won't wait for the next milestone. I'll pull them back in and repeat it and see, is there any more words? Has there been any improvements in any of the motor stuff, or is some other repetitive stuff starting to show itself? So you may have to do those acute visits, if you will, only like 6 weeks afterwards, and keep doing that until you feel you have a sense of what's going on. And again, I would refer to early intervention as soon as possible, because the worst thing is that we were wrong, and I've done it before. I've sent someone there and like, this gets fine, but I'd rather be wrong that way.
Sure. Mark, go ahead. We have Mark is our interim chair of pediatrics. Go ahead, Mark.
Also general pediatrician. I have 2 comments before a quick question. One comment is, in the screening bundle for our patients in the PHO, there's actually an autism screen, and it's not MChat, and I'm trying to remember what the acronym is, and I can't. I think it triggers at 18 and 24 months, if I'm not mistaken. So that's part of the routine screening that the parents will fill out. There's also 2 developmental pediatricians in our PHO. Naomi Gershon is one, and Dr. Levy is a new one. So those are some other alternatives, and sometimes insurance accepting, they can be a little quicker access. My question for you is, excuse me, can you comment on kind of the kids who end up getting a PDD or ASD NOS kind of diagnosis early on, but then they tend to outgrow it.
Mhm.
I have a number of patients who they're a little, they're a little delayed or a little different early on.
Mhm.
By the time they're mid-teens or late teens, they're kind of neurotypical kids.
Yeah.
Thanks.
Yeah, it can happen. It doesn't happen very often, but there are definitely, kiddos where the diagnosis just hits right on the threshold early on. And they just happen to be, these folks that have really good coping and adaptation skills that they just essentially work their way around it. I'm not sure the diagnosis ever disappears. It just becomes clinically insignificant, I guess is the best way of putting it. Because it's interesting, I have some very high functioning patients in my practice, and every once in a while I'll see something sort of sneak through that's sort of reminiscent, I think, of a symptom, but in general, they're just wonderful and do their thing and have their jobs and all of that.
I guess I would ask a similar question to what Mark was asking. Sometimes I get asked, should we be placing my child in a special education program or a special school versus mainstreaming them? And I always feel quite inadequate in answering that question. How do you handle that one, James?
It's a great question. And the way I would answer it is that most public schools and most public school systems are very well set up for this now. I wouldn't say that was true years ago, but I would say that now. And now that, they're required to do all of these things with an IEP and get these kids the services they need, some better than others, but they can really provide everything that the child would need. And the parents just have to feel really comfortable just doing constant advocacy and constant communication and checking in to make sure that they're getting their kids getting everything that they need. So I lead with that. For kiddos who are definitely, as they go through, those early years, and it really seems that their behavior is just too challenging or their communication deficits are too challenging, then there definitely are schools which are catered to, like the Higashi School down on the South Shore is wonderful at working with kids who they're just too many challenges for the school system, and they really are better served there. And that's just a matter of the school system and the parents and everybody coming together and agreeing that they need outplacement services. The challenge for that is that often school systems don't want to pay for that, even though they have to. So they'll resist it. So it turns into a bit of a street fight. But some school systems are good and make sure they care about the kid and they want to make sure they get them into the best place possible. But you start if you have unless it's a really bad public school system with no spec ed department, I say the default is you go to your public school first and stay incredibly involved.
Yeah. And real quickly towards the end here, any favorite college programs? I've had one patient go through the Wellesley College program after graduation, and he's done amazingly well. They had residential kind of training and things like that there. Anything you've come across that we should keep our ears open to for our parents?
Yeah, no place specific. I've always myself been amazed, when I hear patients come in and tell me their stories about how they went up to UMass Lowell and got a great educational program put in place for them so that they could really succeed, and one at Bridgewater State. But it's funny, there's no dedicated place. It's just in that particular school, how much do they value it and how much do they help? So.
Excellent. James, thanks so much for being here. Once again, James is doing primary care up at the Lurie Center, which is brand new for them. And so congratulations on that position. And also he is a great resource, always available, and a well-trained family doc. And we're happy to have him. Thanks again. We'll put this up. And if you need any other information, contact me. I'll get it to James or directly to James. And hope everyone has a nice weekend and enjoy some of the beautiful weather that's starting to turn around on us. Thanks again, you guys. Bye.
Thanks, everyone.